Hi, everyone. Welcome to this first Lunch and Learn of the semester with the wonderful Jonathan Cohen. I'm Sofia Gruskin, and on behalf of the Institute on Inequalities and Global Health, it's my great pleasure to welcome you. And I do want to say this event is done in partnership with the IIGH Student Advisory Council. And it's really different than our regular events in that this is at the request of students in terms of who they want to talk to, but also what they want to talk about. And it really means that we're going to do things quite differently. I mean, basically, I'm going to ask Jonathan a couple of questions casually. We said we're totally informal here. And then open up the Zoom for you all to ask the questions that you want. So it's going to be way more interactive than usual for those of you who are used to attending our events. You can absolutely use the raise hand function or add your questions to the chat. And I also want to be clear that while the request came from students, everyone online is welcome to ask questions or to comment or to engage. Okay. All right. Let me say a few things about Jonathan. Now, some you may know, some not so much. And I'm going to go into way more detail than I would usually, precisely so that it can open space for questions that you might have in terms of his work, in terms of his path, in terms of kind of life. Okay, so indulge me if you will. All right. So Jonathan Cohen is clinical professor and director of policy engagement with us at the Institute on Inequalities and Global Health. And with us, he is spearheading our engagement in Washington, D.C. But when he joined us, that followed a long career in philanthropy, most recently as the public health program director at the Open Society Foundations, where he oversaw a $39 million annual budget to advance social inclusion and a democratic commitment to the public good and health policy and practice. So before that, Jonathan, Professor Cohen, was a researcher with the HIV, AIDS, and Human Rights program at Human Rights Watch, and he has many other professional spaces that he's been in, but those are two in particular I wanted to pull out. Now, he's published widely on a bunch of topics related to the political, the legal, the social, the economic determinants of health. Now, I want to say something about some work that's different than the aging and policy spaces first before saying more about the aging and policy spaces. So, he is currently producing the Health and Human Rights Oral History Project, which is a digital archive of 30 years of pioneering work in the health and human rights field. And it's kind of incredible, kind of what he's pulled together in terms of this oral history project, which is going to be formally launched in December. All right, so those are some things you might want to ask him about. Okay, now in terms of the work on aging, when he was on sabbatical from the Open Society Foundations in 2018, he conducted some research or independent research on sexual and gender diversity and aging, including issues of chosen family, non-traditional models of care, and critical gerontology. Now, over the next year, starting right now, he's serving as a health and aging policy fellow in Washington, D.C., as part of a cohort of emerging leaders in the health and aging field in the U.S. So that's aging. Now, importantly, his work at Open Society is also credited with having helped to build the field of human rights in palliative care, including the integration of legal services into hospice and the conceptualization of access to pain treatment as part of the right to be free from torture and inhumane treatment. So the whole issue of human rights in palliative care is another avenue we might want to explore. So I'm just saying there's a lot to talk about, right? So I kind of want to parse things out to start. I mean, I think what's really exciting about what Jonathan is doing, he's really at the forefront in terms of bringing aging together with the health and human rights framework. So let's kind of pull back for a minute. And Jonathan, if you don't mind, I want to start with a biographical question, all right? You come to the field of healthy aging and frankly, the field of public health with this background in human rights. So how did you get into human rights in the first place? And can I ask with that, how do you define what it means to do human rights work?
Thank you, Sophia. Thank you, everyone, for being here. Thank you for this opportunity, and thank you for that question, because I think, I do come to aging, and I come to any health issue with a human rights orientation. So I think it is important to understand that orientation and the source of it, and it's something I've been thinking a lot about. I think that human rights is in my DNA. Um, I am the grandchild of Holocaust survivors who fled what is now Western Ukraine before the Nazi invasion, found themselves back in a displaced persons camp after the war where my mother was born, in a DP camp in 1946. 1946 was also the year that the UN General Assembly met for the first time and vowed as an international community never to repeat that kind of atrocity again, and made the decision to complement the UN Charter with what would become the Universal Declaration of Human Rights. And then my family, my maternal grandparents, my mother and my aunt, when they got out of the camp, would immigrate to Canada, where I was born. They immigrated in 48. And indeed, the blueprint for the Universal Declaration of Human Rights was drafted by a Canadian jurist named John Humphrey. So I just think that, and I was always aware of this like incredible human rights tradition that I was reared in that was also so personal to me and to my family. And so by the time I went to law school, it was obvious to me that I was interested in following in that tradition, and I had the good fortune to study under and be mentored by some of the titans of the international human rights field in Canada. So I'm thinking, of course, of people like Rebecca Cook, Erwin Codler, Louise Arbour, and there was just a lot of professional inspiration there. I mean, the last thing that I'll say, and I used to think it was kind of ironic, and now I think it's actually kind of serendipitous. I come from a family of doctors, so I always used to think and joke that by going to law school and studying human rights, I was kind of veering off the path. And I no longer think that, actually. I think that fundamentally, medicine and human rights law are both, in their essence, concerned with the same thing. They're both concerned with relieving suffering. And even more deeply than that, they're both interested in relieving suffering through a process of critical thinking. That's what I see doctors doing. That's what I saw my late father, who was a doctor, my brothers who are doctors, my own doctors doing. And that's what I enjoy doing as a human rights lawyer. So that's a bit about me and human rights.
Okay, well, that's great. I think that, all right, let me push if I can just a little bit. And again, everybody, like, I hope you have questions that are starting to burble up, right? So, when you think about that, all right, so you've talked about human rights law and you've talked about human rights in your background, and you've talked about medicine, but then there's public health and then there's global health. So how did that happen? Like, can you just give us some of that? Then we'll get to aging, but I think this is just important kind of framing, if that's okay to ask.
So I'm going to explain this, but that's actually partly your fault, Sophia, and I'm going to come to that. But really, through a series of personal and professional circumstances, I became, in my 20s, just totally seduced by the field of HIV/AIDS and human rights. Um, and part of that was deeply personal for me. I came of age as a gay man at a time when HIV was still a death sentence. So by the time highly active antiretroviral treatment came out, I had already graduated from college. So I really spent my formative years thinking um, that, frankly, not only HIV, but even homosexuality was like courting death. And so the opportunity to work in the HIV field was profoundly cathartic. For me, it was a way of sort of leaning productively into those fears. But I think more deeply than that, what the field of HIV/AIDS and human rights gave me, and I'm crediting you in part for this because you're such a pioneer in that field, was an understanding of how I could contribute to combating this epidemic that had so terrorized me as a lawyer, right? Like it said to me, you don't have to be a physician to make a difference here. In fact, while we very much need physicians to combat HIV, it's not going to be nearly enough. That the law is an equally powerful, in some cases more powerful tool in combating HIV. Why? Because the law can address the things that make you vulnerable to HIV in the first place. The law can get you out of prison where you're vulnerable to HIV infection. The law can get you out of a violent marriage or relationship where you are profoundly vulnerable to HIV. The law can lower the price of medicines and make them accessible to people with HIV. So it was that realization, and I would say ultimately the power of collaboration between the medical profession and the legal profession, which we've seen so powerfully in the AIDS responses in places like South Africa and Brazil, that really drew me in. And you were actually, when I was like 25 years old, one of the people who I wrote. I know you get 10,000 of these emails every day saying, I really want to get into this field of HIV and human rights. And, you wrote me back, and that was encouraging, and one thing led to another. And then from there, from HIV, it really was a natural process and a very exciting process of applying the human rights framework to many other health issues. And that's what I had the opportunity to do at Open Society for 16 years, because at Open Society there was this incredible canvas of work on public health. They were working on harm reduction and addiction. They were working on mental health, on palliative care, on access to medicine. So the opportunity there was to ask, okay, what does human rights look like when it's applied to all of those different fields? And it was a fascinating thing to see, and the differences were as interesting as the similarities. So, in the introduction, you talked about how we helped to birth the field of palliative care and human rights. I mean, that was what I think human rights did for the field of palliative care and continues to do more than anything, in my opinion, is really bring about a shift from the idea of palliative care as one of those kind of nice to haves, as a kind of charitable thing. I mean, that was very much, some of the early palliative care practitioners were acting very much in a humanitarian tradition, in a compassionate tradition. Many of them were nuns. To no, this isn't a nice to have. This is a right to have. If you don't get it, you have been failed by your duty bearers. There is recourse. This was not a language that palliative care providers were used to using, but were all too excited to use. So that, and it was really a language of accountability, ultimately, that if governments don't facilitate and allow the provision of palliative care, they've got something to answer for. That's so much what the human rights move does. And then in other fields, it was and it is profoundly about social inclusion, right? So we did a lot of work with criminalized populations, with people who use drugs, with sex workers, with trans communities, and it was always so fascinating to see the move from people saying, well, I'm a drug user, I don't have any rights, to I'm a drug user, my rights are being infringed. That's so much of what the language and the thinking of human rights does. So it was always really about those two things. It was the accountability piece and the social inclusion piece, regardless of which health issue you were working on.
I hear you. I totally hear you. Okay, so let's go to aging. Okay, because which is what folks who are on this call thought we were going to be talking about. But I think this is super important, and I'm going to want to take us back to palliative care in a minute. But I'm really struck that aging is relatively new for you in terms of kind of what you've been working on. So I guess, what drew you to the field? And obviously we're all getting older. I mean, clearly, but, wasn't getting older, but really what brought you into that space?
Yeah. So there's getting older, although, and I think more deeply than that, it's the fear of getting older and asking yourself, why am I afraid of this? What kind of combination of internalized ageism, interpersonal ageism, structural ageism is making me afraid of this? And of course, fear is what got me into HIV too, right? So there's a theme there. There's kind of a leaning into the fear and interrogating things that I find stigmatizing, So there's that. There's the fact that it's the opportunity to work on just a tectonically important issue for our world, like really on the level of climate change or, nuclear proliferation. It's existential. I mean, you look at the landmark report of the National Institutes on Aging, and they point out that any minute, if it hasn't happened already, for the first time in human history, the number of older people is going to outnumber the number of younger people. This is, of course, because of changes in birth rates, because of changes in fertility, changes in life expectancy. And this just raises profound questions about what later life is going to look like. Will it be accompanied by a period of good health and thriving, or will it be accompanied by a period of just profound fragility? What will safety nets do? What will health systems do? How will this affect healthcare costs? The cost of social protection? How will the inevitable scramble for resources be handled? How will different countries respond to this? Will those responses be aligned with human rights-based thinking? Will they enable older people to thrive, or are we looking at more coercive scenarios? How will these scenarios differ in wealthy countries versus low-income countries? How will the combined effects of population aging with climate change, with the new pandemic era play out in a context where we can already see from extreme climate events as well as from COVID that older folks are disproportionately affected? What is our understanding of that? That can't be an afterthought in a world where older people are the majority. It has to be at the absolute center of our thinking about how to respond to complex humanitarian emergencies and pandemics. And we very much failed when it came to COVID. And so then related to all of this, it's the opportunity to not just work on this earthquake. But to apply the health and human rights framework that we've been talking about to it. And I think it's a field that could very much profit from attention to that framework, from ideas of again, social inclusion and accountability. So when I think about social inclusion and healthy aging, I think about human diversity. I think about the diversity of people who age. This is not a homogenous group, right? I mean, ageism intersects with racism, with sexism, with xenophobia, with homelessness, but when we think about, and when the field of aging talks about this idea of healthy aging and successful aging, which is a term that just the field is saturated with, are they thinking about an older prisoner and their ability to age successfully? Are they thinking about an older homeless person? Are they thinking about someone who's totally isolated in a skilled nursing facility? I think if they were, they probably wouldn't be talking about, you too can age successfully, and human rights is very experienced at asking the question about the environment, the enabling environment, right? In equity, people are fond of saying, right, the choices you make are a result of the choices you have. And that's very aligned with human rights thinking. So that, there's just so much opportunity, I think, to ask who's left out of this paradigm of healthy and successful aging, and how can we address that? And that's very linked to an emerging field and practice of critical gerontology, which is putting that critical lens on the field, which I find very exciting. And then there's the accountability piece, right? So if there's this idea that is often, I think, sold to people that successful aging is up to you, right? You make the right choices. You can age successfully, you can age fearlessly, you can age gracefully. There's just so many adverbs around it, and I think the accountability piece recognizes that how you age is not just a matter of individual choice, it's a matter of the political choices that shape the environment in which you age, right? So going back to what I was saying before, political choices that manufacture human fragility and human precarity, political choices around homelessness, around criminal justice, around the oversight of nursing homes. I mean, ultimately, policymakers are making choices, right? And human rights is nothing if it's not accountability for those decisions. So I guess having, gotten so much satisfaction out of seeing the human rights framework applied to so many different health issues, I couldn't resist the opportunity to bring it to bear on this one, which is, by the way, going to affect every single other one. Yeah.
100%, 100%. I'm going to open it up to other folks in a minute. I just have really kind of two questions that I kind of want to lead in with, but just to talk about this. I know that your first foray into the aging field was related to sexual and gender diversity, and in terms of what's so-called queer aging. And listening to your history, it's kind of clear what drew you there, but please expand on that. But I also am curious, what did you discover? What did it tell you about the strength of the health and human rights paradigm? What did it tell you in terms of thinking about aging and generally, and the kind of critical reflections that you're making now?
Right, thank you. Oh, I really, beyond the obvious, I was drawn to the issue of sexual and gender diversity and aging for so many reasons. So first of all, at Open Society, we were working a lot on different issues of gender and sexuality, right? We were doing a ton of work on HIV, on sexual health, on transgender health, on the health and human rights of sex workers. But I have to admit, we were no exception to the structural ageism. I mean, our work on that was totally like age blind. You know, we were not asking ourselves, what are the unique needs faced by people who undergo a gender transition later in life, who age with HIV, you know, and I think I felt in a way complicit in a kind of age blindness there. I think that, you know, if you define structural ageism as a set of implicit biases around age that we allow, absent proactive action, to permeate our institutions, to permeate our work, you know, we were no exception. I think it's probably true of most institutions, frankly. So there was something I wanted to do to correct that. And then as I looked into it more closely, it became clear that sexual and gender minorities who are older, I mean, it's a classic intersectionality scenario. You know, they are victims of a double discrimination, often from within their own communities, right? So there is profound ageism within the LGBT community, for example. And there similarly is a huge amount of homophobia within the aging field, the aging space. And, you know, we know from Kimberly Crenshaw and intersectional theory, what happens when you are at the intersection of two oppressions? You vanish. You vanish, you disappear, you fall right through the cracks. And it's remarkable how much of the very small literature on queer aging, on sexual and gender diversity and aging talks about invisibility. So it really, and I think that also links back to human rights, and you've seen this so many times, that human rights is so much about making the invisible visible. So I pursued 3 or 4 specific questions during that sabbatical research. I wanted to know, first of all, how is it that any kind of divergence from conventional kind of patriarchal norms around gender and sexuality, right? And that could be anything from, you know, not identifying with your assigned gender at birth, to, you know, living in a polyamorous relationship, to, you know, choosing not to reproduce and have children. Like, these are all ultimately deviations from the patriarchal heteronormative model. Like, how those kinds of choices affected one's experience of aging and later life, just kind of empirically, and what were people saying about that? And then the second question is, how were communities responding to that? How were queer communities fashioning authentic ways of aging, ways of being, you know, given that they were aging, I like to call it aging off script, you know, so how were they living off script? What did that look like anthropologically? How were they living in chosen family? How were they living in intentional community or co-housing? How were they living in intergenerational relationships? And that's not an easy thing to research. It's just sort of like society, you know, it's, and then I was also interested, and this is kind of a human rights question that, again, you could apply this to so many fields in the policy environment. To what extent does our legal and policy environment enable that kind of human diversity, enable people to age authentically in their full sexual and gender diversity. So what kind of laws and policies do we need to enable that? And then lastly, I was sort of interested in the question, which is very much familiar to people who are interested in queer theory and queer liberation, which is how can these unique ways of being go on to, in a sense, liberate the entire society, right? Because, we don't, as queer people, just want equal participation in the institutions that have historically excluded and oppressed us, whether that's the institution of marriage or the institution of the nursing home. We want to change those institutions, in a sense, free them from themselves. And you've seen that in the way that, ACT UP forced a rethink about what healthcare looks like, or the way in which marriage equality actually helped people rethink traditional ideas about marriage. It wasn't just about mimicking heterosexual people. It was sort of an act of liberation, not just equality. So it was fascinating research. I mean, this was a sabbatical project. It wasn't like super rigorous qualitative research. I think the second question about the unique ways of being that folks were fashioning was by far the most interesting. And one of the things that I discovered in doing that is that a lot of those practices were very disconnected from each other. There was no way for people to know what others were doing. They were shareable large. I mean, I heard about a lot of them through word of mouth, and oh, you should talk to my friend who's setting up this amazing co-housing thing, and then you call them. So I got very interested in community building around this issue as a way of sharing knowledge and resources. And by that time, we were mid-pandemic, and it was lockdown. And so the way that I pursued that was, I don't know if folks in the audience are familiar with the social audio app called Clubhouse, but it's one of a bunch of new apps where people essentially get on the phone and talk to each other without seeing each other about issues that they care about. And in February of 2021, with no experience with this app or any kind of social audio, I just decided to open up a room on the app about queer aging. And, people came in, and they came in, and all I would say is, well, what brings you to a room called queer aging? That was just my question. And the answers were like totally amazing. It was like, well, I couldn't believe when I saw this topic. I'm a lesbian in her 60s, and my younger non-binary partner and I are trying to figure out where and how to live when we get older, and I thought I'd get ideas from this group. Or, I'm a millennial caregiver, and I live in an intergenerational home with my gay uncle and his friends in San Francisco, and like I am their caregiver, or I am a Spanish postdoc who just wrote my PhD on changing body image among queer people as they get older. Like, it was just like totally amazing to hear what these people are saying. And this club just took off. We have not missed a week since February of 2021. We've met every Sunday for 2 hours for almost 2 years now. There are over 1,400 members in the club, and I mean, people describe it as like, this is like going to church for me every Sunday, or I've met my best friends here. So it's been quite a remarkable community building exercise around a really neglected topic.
That's so awesome. That's amazing. All right. I want to make sure other folks, I have like a million questions myself, but I realize I can do that later. So I want to please everybody put up your little hand, your little hand thing. And so I'm looking for hands for people. I'm happy to keep going if nobody's putting up a little hand. So, all right, I'll keep going, but please everybody do do kind of throw yourselves into the mix, is that I would appreciate this, because I think I think there's a lot of different strands to this. I mean, I guess one question that I will stop. So then please, Gisa, please.
Lisa, yeah, thank you. I wanted to wait because I'm not a student. I have profited from Jonathan's work in his previous life at OSF, and I also come from the HIV/AIDS human rights and community space. And so one of the things that, you know, I've been working on with Treatment Action Group in New York is trying to figure out how we can bring different human rights and into, you know, conversations about infectious diseases, but also into broader societal concerns. And one of the rights we've been talking a lot about is the right to benefit from scientific progress. The ability, I mean, the obligations on states to develop, diffuse, and conserve, you know, tangible and intangible scientific goods. And so one of the things where, you know, our work kind of overlaps has to do with participation, and that participation in science and participation in policymaking. And correct me if I'm wrong, but my assumption is that an aging population is also a population with less access. And like, excuse the noise in the background there. So with less access to policymaking and less kind of say in terms of power dynamics of how decisions are getting made. And so I was wondering, you know, how does that factor into your work? Where do you see kind of entry points for broadening participation? Again, trying from this idea of, you know,
Great.
People as they age as a community and having their say about their own human rights.
Awesome, thank you. Jonathan.
It's great to see you, Gisa, and I'm so glad you're at TAG, and I'm so glad TAG is thinking about these issues. And gosh, the right to benefit from scientific progress. I'm sure Sofia has some thoughts about that particular right too. I think I'm glad you raised it. You know, when I think about that particular human right as applied to the older population, I don't think it's just, it's not just about access, right? I think and you'll relate to this, it's about the fact that older folks are thought of as a market for commodities that come out of scientific progress. So, and what we need is a shift, and I think human rights would compel a shift from seeing the fruits of scientific progress, whether those are pharmaceuticals or any number of technologies, not as commodities to be bought and sold, but as public goods to which everyone deserves access. And that would completely change the way we thought about the entire value chain, how we prioritized the creation of those products, the development of them, the pricing of them, the distribution of them. Of course, we saw this tragically play out with COVID vaccines, which were utterly commodified, not treated as a public good. I'm, sure that's part of what got you into this. But another issue that I would really look at when it comes to the aging population is digital technology. I mean, without a human rights and public good analysis, what you'll hear is that population aging creates huge market opportunities for digital technology, right? There's an app for everything, right? There's an app for, monitoring your blood pressure at home. There's apps for telemedicine. There's apps that keep you company. There's apps that help you manage your prescription drugs. I mean, there's tens of thousands of them. Some of them are useful. Some of them are not. Most of them are driven by profit. But where does an equity approach, a human rights approach, a public goods approach take you? Exactly to where you said that community to participation, that communities must have a say in the design of these, this emerging notion of design justice, that equity and access need to be built into the business model, into the revenue model from the very beginning, so that what you get, I mean, in some ways it comes right back to the right to health, is digital health technology for older persons that is what? Available, accessible, acceptable, and of high quality, as opposed to driven by market incentives. So I hope that sort of begins to answer the question. Yeah.
I mean, can I push on that a little bit more? And then again, folks, please raise your hands, come into the conversation, because that's how we've set it up. But I think there's also this question about kind of how human rights in general can be brought into healthy aging, right? So thinking about what is it that the health and human rights model offers. And I really appreciated the framing in terms of the benefits of scientific progress and in terms of participation. But I just wonder more broadly, in terms of thinking about health and human rights, are there ways that you think that this can really be helpful in terms of the field?
The right to the benefits of scientific progress?
Not only the health and human rights framing, like in general, in terms of thinking about healthy aging, like whether there's kind of more broadly.
Absolutely. And I think, no, I'm glad you asked. I think in some ways we have to start broad. We have to go broad before we go narrow. So the way I would answer that question, well, just logically, I would begin with what is healthy aging? Like, what is it? So I looked this up. Well, many of us know it. The World Health Organization has a definition of healthy aging that I think is very helpful in answering your question. They define it as the process of developing and maintaining the functional ability that enables well-being in older age. Okay? And I think there is a lot in that definition, even though they're not saying human rights, that very much resonates with how human rights people think, right? So there's this idea of enabling well-being, not guaranteeing well-being, but enabling it. So we like to say in human rights, you don't have a right to be healthy. That doesn't really make sense. But you have a right to the potential to be healthy. You have a right to the conditions that create the opportunity to be healthy. And we speak of the enabling environment. I think that very much applies to the field of healthy aging. And we've also learned from the health and human rights field that many of those so-called enablers, right, the things that enable well-being along the life cycle in old age, correspond to what? To guaranteed human rights. So what would be an example of something that enables well-being in older age? Housing. Housing is a human right. An adequate standard of living. Another human right. Freedom of movement, or the freedom to decide where you live, to be free from inhuman treatment in institutions. Also a human right. So I think that's how I would begin. It's through this idea of linking recognized rights to this idea of enablers of well-being. But then there's this idea of well-being itself, which clearly picks up on the WHO definition of health, right? Because WHO defines health as what? Not just the presence or absence of disease, but as what they call a state of complete physical, mental, and social well-being. So they're clearly, in my opinion, biased, drawing on their definition of health in defining healthy aging. And again, if you define health and well-being that way, in that holistic way, then it's also linked holistically to a range of other human rights, what is it that allows people to enjoy well-being and
Yeah.
experience well-being? It's not just whether you're sick or not. It's the right to work. It's the right to play, right? It's the right to express yourself. It's the right to associate and assemble with others. So I think both the enabling piece and the well-being piece, in a sense, kind of map out a human rights agenda for healthy aging. But I don't know. Maybe this is. I really want to know what you and others think of that.
I got you. No. Okay. Well, let me pull us back for a minute. Let's kind of get more concrete. And again, everybody, the floor is open. But why don't you say something about the fellowship that you're doing, right? And tell us a little bit about what that fellowship is going to be about in Washington. Is this the kind of stuff you're going to be working on?
Yeah, it's so. So let me say a little bit about the fellowship, because I don't know yet exactly what I'm going to be working on, but this is a
Fair enough.
fantastic, huh?
I said, fair enough. Go ahead.
Yeah. No, but they keep telling us, don't decide yet. Take your time. It's a great program. It's run out of Columbia University. It's in its 15th year, and they select about a dozen people a year. And provide us with, a year of orientation and placement opportunities and mentorship in Washington, D.C. in order to cultivate future leaders in the health and aging policy space. And so for the first few months of the fellowship, which is happening now, you get this very intensive training in health policy and in American political science, and you spend that time finding a placement in Washington, which I'll spend about a fifth of my time on, either on Capitol Hill, with a congressional office or with a committee, or with an agency of the executive branch, working on some aspect of health and aging policy. So my pitch to the fellowship program, which was successful, was to work at the intersection of global health and aging. And they tend to have like one or two global health fellows a year. Most of the fellows are working on U.S. domestic policy as it affects health and aging. But broadly, what I'm interested in and hope to pursue is the way in which the U.S. government's investment in global health, which is massive. I mean, we're talking about like tens of billions of dollars going to AIDS relief, going to the Global Fund, going to humanitarian assistance, that older adults are really invisible in those investments. It's not that they're not benefiting from them at all, but there is not specific attention to the needs of older adults. There's certainly not an understanding of how global population aging needs to force a kind of rethink of how we approach global health. So I really hope in my fellowship year to be working on some aspect of that, but the question is which aspect and where is there like policy motion in Washington on that issue. So, just to give you a few examples, I mean, the U.S. funds a lot of foreign disaster assistance in response to war and climate events. How much are they targeting older folks in that assistance? Pandemic preparedness is obviously a huge new issue right now. There's pandemic preparedness. There's tons of pandemic preparedness bills that have been tabled in Congress. How much are those bills learning the lessons of COVID in terms of the way in which some, not all, but some pandemics go laser-like into the older population, and nursing homes have to be prepared and families have to be prepared. So I think I need to spend the next couple months figuring out where the levers are to advance this larger question of embedding what you could call like intergenerational equity into US global health. There's a ton of attention now on embedding racial equity, gender equity, not only into global health, but into every aspect of the US government. I mean, every agency in Washington right now is writing its racial equity action plan. But I think, again, it's a real shame that when the Biden administration issued its executive order on equity on his first day in office, and they listed all of these groups who are historically underrepresented and victims of structural discrimination, they left out older people. They didn't talk about ageism. They didn't talk about intergenerational equity. So, where there's a gap, there's an opportunity, and that's what I want to focus on.
Awesome. I mean, and it's so needed. There's a great question in the chat that I want to get to, but I have one quick follow-up to this before, which is, I mean, we're talking about DC, there's the midterms coming up, right? So I guess my question to you is whether you think that aging issues are going to figure into the midterms in any way. If there's anything about that to be said.
I mean, I think if you'd asked me, like in the 2018 midterms, I would have said 100% yes, because as people will recall, healthcare was the issue in those midterms. It was all about saving the ACA, and Democratic candidates peeled a lot of support away from Republicans over the issue of pre-existing conditions, and rightly, I think, pointing out that, if you elect a Republican Congress, that the prohibition on denying people with pre-existing conditions health insurance that exists in the American, in the ACA, in the Affordable Care Act, will go away. And that profoundly affects older folks. I mean, anytime healthcare is on the ballot, aging is on the ballot. This time around, I mean, the Republicans are largely running on inflation. The Democrats are running on abortion. They're running on gun control. They're running on saving democracy. So I don't see it as much. That's not to say there are not really politically salient issues right now that profoundly affect older Americans. So, the Inflation Reduction Act has this landmark provision that allows the administration for the first time ever to negotiate Medicare drug prices with the pharmaceutical industry. That has a big effect on older Americans. That's a big one.
Yeah.
Yeah.
I got you. No, I got you. I just, yeah, thanks.
Yeah.
Thanks for that. I mean, so the question in the chat takes us back to palliative care, I think, in some really important ways. So I guess the first thing is I think there's a two-parter here. And I guess the first thing is if you can point to really a concrete difference that's been made by applying a human rights lens to palliative care, just kind of very explicitly and concretely. And then are there any parallels or any ways that what you're talking about could be applied to the dementia area?
Yeah. I mean,
and you can let me know if I need to be more specific. I'm the one who asked the question.
It's a great question, and in some ways, I mean, I'm gonna have a try at it, but I would really want someone from the palliative care community to also answer this, because I think you would want the perspective of someone in that field who saw the difference, right? Who saw what the field was like before, during, and after. But, concretely, I think one of the big differences the human rights approach made was that programmatically, a lot of hospice and palliative care organizations started integrating legal support into palliative care. Like they started understanding that, okay, if palliative care is holistic, that's healthcare, it's spiritual, it's also legal. And there are so many issues at the end of life that affect wellness in a holistic sense, like, succession planning for your children, or I remember we were doing this all over the world. So for many people, it was about, customary laws whereby people like grabbed your property as you were dying, and that being able to provide people with legal support during that very precarious time at the end of their lives made a really big difference in their lives. And I would imagine the same is theoretically true for dementia. I mean, there are actually really profound issues around agency and empowerment and conservatorship and choice and decision making. So I'm very intrigued by this issue of this idea of like, the lawyer or the paralegal on the interdisciplinary care team. So that was a concrete thing. And I'm not going to say now, like, do that for dementia. I mean, it would have to be very carefully thought about. I think another thing that was very concrete was this issue that I mentioned before, which again, a lot of palliative care people were nervous about it, but I think it worked, is that we really were able to raise the stakes around the denial of pain relief and talk about the denial of pain treatment as a form of torture and cruel and inhuman treatment. And the thing about that legally is that it's one of those rights that is absolute. There is no deference accorded to governments when they are torturing people and degrading them. And again, I mean, so based on that, we funded kind of creative campaigns in different parts of the world calling attention to denial of pain treatment as a human right, as part of the right to torture. We got the UN Special Rapporteur on the right to be free from torture to issue reports about this. And some governments responded. I mean, it ended up providing a lot of fuel to very specific policy debates, like around whether nurses could prescribe morphine or what kind of dosing of morphine people were allowed to bring home. It made policymakers aware that a lot of these sort of bureaucratic rules were actually resulting in preventable suffering that amounted to a form of torture. Now, I don't know what the equivalent in dementia would be. I would venture that there are human rights lawyers out there who would find that some of the conditions in which folks with dementia are forced to live amount to a form of, if not torture, then certainly cruel and inhuman treatment. And one has to tread carefully and do this in a collaborative way. And I guess the question would be, are there places where bringing in that language might help propel a policy discussion forward that otherwise is kind of stagnating?
Dr. Mosqueda, does that answer your question?
Yes, it was very, very helpful. Thank you. I mean, I think it really strikes me when you're talking about this that essentially everybody in a nursing home was put into solitary confinement without their permission. And that might be another example, because certainly a lot of those folks have a dementing illness. But yes, thank you. That was very helpful.
And has that language been used of solitary confinement? Or is that your...
I've been using it
sounds right to me.
in the past year or so.
Yeah. So then, I was in philanthropy, so then the way a funder would think about that is, all right, there are lots of organizations out there who do nothing but solitary confinement. But have they met you? And have they met folks in the dementia community? And lawyers love a new fight. They love a new battleground. So if then we were able to pay to, it was a lot of bringing folks together for those dialogues. And can the language and the tools that we use as lawyers, and can the mechanisms of redress for solitary confinement, can they be useful to you here? It's a conversation perhaps worth having. Yeah.
So I have to say we are at time, but I have to say that the hour has just flown by. And it's been wonderful. And thank you, Jonathan, first of all. That was amazing. And thank you for being so lovely and responsive to everything. And thank you all for being with us. And I hope you enjoyed this, and I hope we can have more such conversations. And just take care, everybody. And let's do more of this, because it seems really important and useful. And thank you.
Thank you. Thanks, Sophia.